Good morning. Okay, we're going to call this the A section and the B section and the C section. Good morning, C. Good morning. Good morning, A. Good morning. Good morning, B. Good morning. B wins for this round. Anyway, all right, let me get myself organized here. So, welcome. My God, those lights are bright. Very glad to see you all here, and I know that, oh, thank you. I know that more people are going to be showing up. We've got over 300 individuals signed up today, and we've got a number of people who are joining via Zoom, which was a last-minute thing we did. There are a number of people getting COVID, and a number of people who decided wisely and correctly not to be here today, and so they're joining us remotely. Hope you all feel better. So about Delaware Health Force, we're focused on four things. We're focused on data and research, really understanding the nature of our workforce, license type by license type, board by board. We're interested in the expansion of graduate medical education, be it for physicians, for nurses, for various therapists, allied healthcare professionals, and I know that that's not a popular term, but it's what popped into my mind. Sorry. We run Delaware Mini Medical School, which is a starter program. It's the beginning of the pathway. Hopefully, students who are in 5th grade through 12th in undergrad school will choose something in the healthcare profession later down in life. And we also have taken a part of the ARPA funding, and we're doing interest-free loans for Delawareans going primarily to Delaware institutions to pursue a variety of degrees except for physician and dental training, which we already had a loan program for. So in any event, that's about the Delaware Health Force, and I want to hit on one word in the sort of that those 5 words here, and that's reframe. We're at a difficult point, as everyone knows. You're here, you understand, we have shortages, we have burnout, we have an aging provider population, we have all sorts of stresses, and reframe is the word that I want to focus on. This represents opportunity. Opportunity to collaborate in new ways, opportunity to leverage technology in new ways, thoughtful dialogues with payers about how we can speed up the process of practitioners being compensated for the work they do on behalf of the patients that the payers and the providers share. There are a number of things we can do together. So we need to reframe this. We need to come together as a community more than ever. We need to double down on that collaboration. So at this point, I would like to have my voice crack. I'd like to invite Rebecca Walker to come up to the podium. Rebecca, wherever you are. She's talking with somebody. And there she comes. Quite all right. We understand the work is never done. All righty, and Rebecca Walker is with the Division of Public Health. I'll allow her to introduce herself further. Ladies and gentlemen, Rebecca Walker.
Well, I can tell you one thing. Tim wasn't wrong. That light is really bright. I feel like a rock star person. So what I'm going to ask first, if I could, real quickly, if you are a clinician, anybody who holds a license in something, do me a favor if you would and stand. Okay, so you're almost half the room, right? That's awesome. I'm a nurse. That's very important to me too. All right, have a seat. If you are in a leadership role or oversee a team or make business decisions, stand. That's about the other half of the room, if not also clinicians, right? Okay, guys, have a seat. So what does that tell you? First off, this is a sold-out event. kudos to you guys planning this. It was obviously a very important topic. Second of all, it's a cross collaboration between two groups. That's awesome, bringing the right people to the table to have those important and hard conversations so that we can value each other's perspective and move forward. This issue that we're going to discuss today and some of the presentations and some of the panels, they're going to be really informative. This is not just a Delaware issue. I am one of the deputy directors in public health. I oversee all the clinical science operations sections within them. The clinics, how we utilize nursing staff, how do we utilize community health workers, how we utilize our epidemiologists and other caseworkers and individuals who have that direct line impact to people's health. What can we do that expands our scope? How can we expand or make sure that our providers and our clinicians are working at the top level of their license so that other work that they might not need a license to do can be incorporated into something else? How else can we get that work done? Those are the kinds of hard decisions and the conversations that I think we need to start having, all of us, not just us in government, but us also in organizations. What are we doing to promote lifelong learning? There is a lot of really good programs in your pamphlets today. Please bring these back. Show your staff members that there are options and opportunities for them to continue to learn. What are we doing for staff wellness, retention, resiliency? I would say that there's 4 key concepts. If I keep stepping away, I apologize. I have a habit of walking around, and then I also noticed that my heel just got stuck. So you know that lady that this gets healed? That would be me. They call me Grace. There's 4 key concepts I would like all of you to consider as you're listening today. The first one is resilience. Everybody that is here has lived through that pandemic that, yes, we keep still referencing because it's still in our head and we're still, responding to it. We've gotten through it, and you're all still here. That demonstrates that everybody in this auditorium is resilient. If you work in high intense areas and you're still here, kudos to you, you're resilient. If you've led organizations and kept things going, you're resilient. We got to keep promoting that resiliency. It's not bad. Having that strength is a good thing. Being kind with that strength is a better thing. The second thing I would like to talk about real quick is retention. How do we retain people? Oh my gosh, we lose people left and right. Look at the numbers of respiratory therapists post the pandemic. Their numbers are down big time. And that's a very professional statement, down big time. They're down, but we're working through ways to figure out how we can make sure we build them back up and we get those providers back to the bedside. Promoting that culture of lifelong learning, staff wellness, doing something very small, might seem very small, but it can have a big impact. Identifying a group of people, sending out something and saying, hey, anybody want to go walk at lunchtime? Anybody in the organization or in this building that wants to go walk at lunchtime, meet at this spot under the tree or whatever at noon every day, and we'll take a half-hour walk around the campus. It helps people get out because they know they're going to be included. They know there's someone who's going to be there with them. They're not doing it alone. And people are like, where'd you go? It's and then they'll develop new relationships, right? They'll be able to talk to other people in the organization and grow. Inclusion. When I say inclusion, I like to think of inclusion as including everybody. And when I say that, I mean, and this might not be a very popular statement, however, a lot of leaders go to a lot of conferences, and it's important information that we get there. But what if we took one of those conferences and sent those funds down to the frontline stakeholders, the frontline workers that are contacting every day those clients, and show them that, hey, we value you. You're important to this organization. We want to keep you. We're going to send a group of you to a conference, and here's how we're going to do it. Or reach into one of those middle managers or somebody that's on your team and say, hey, I'm going to this conference. Come with me. I want you to see what's going on so you know that you're important in this organization. We want to keep you. We want to retain you, and you're valued. Several decades ago, if you're a native Delawarean, like many of us in the room, because I recognize a lot of you, there was an organization where everybody seemed to work there. Your brother, your mother, their sisters, their cousins, their grandmothers, everybody in generations worked at the same company in Delaware. And I'm just trying to figure out how the heck they did that. so that they had that retention, they had that resilience, people were proud of where they worked for, and we were empowering them to be able to gain and grow in that organization. And for those of you who don't know it off the top of your head, it's DuPont, right? Oh, I'm so glad I wasn't the only one. It just came right to your head. So DuPont did that. We can learn from organizations outside of healthcare. We don't have to stay in the healthcare world. Let's look at what Google's doing. How are they promoting innovation? How are they getting and energizing staff to be able to perform at a higher level who were proud and excited to be there? What can we do to make that happen? Not just within our government, but within our private organizations, everybody. What can we learn from other business groups? And lastly, there's a place for everyone. There really is. And there is work for everyone. No one is too proud. Everybody can be included. We have community health workers. We have clinicians. We have physicians. We have other providers. We have mid-level providers. We have educators. We have people with disabilities. There are people across the board who have a value and can make an impact. Us people getting older are also we're here, we're still here, and we want to continue to do good work. Volunteers, veterans, everybody has a place. And all I say is, as you go through it, if I could challenge you to do one thing, you're listening to these panels and you're listening to these good speakers and they're providing you a lot of good information. Pick up one thing, one item, bring it back to your organization, try to implement it, if not within the big organization, within your team, and see what impact that makes. Show your team that they're valued, promote that resiliency, promote that retention, and have a great day. Thank you, guys. I appreciate you joining.
Thank you, Dr. Walker. All right, I'm going to introduce our two co-chairs now. First, Nichole Moxley. Nichole is a senior level manager who oversees the state primary office, state office of rural health, and the Conrad State J1 visa waiver programs for Delaware. Nichole specializes and manages these programs to alleviate access to healthcare issues in Delaware. She engages and leverages partners and stakeholders to support and develop health systems to address the healthcare needs of diverse community populations. She holds a Bachelor's of Science in Business Management from Wilmington University. Nichole, come on up, please.
Well, good morning, everyone. Good to see everyone's faces here on this rainy Wednesday morning to talk about health workforce concerns, and they are very large in Delaware. As Tim said, I do oversee the Primary Care Office, the State Office of Rural Health, and the Conrad 30 Visa Waiver Program, and they are very important to our health systems because us understanding where the shortages are, where to place the clinicians in need, how to properly leverage the J1 visa program and the HHS waivers so that we can make sure that we have providers giving that very important primary care. What's happening in oral health, what's happening in dental health, we have shortages across the spectrum. So if I don't know you or I don't have your email, please let me know because I do like to push information out on all of my programs. We facilitate National Health Service Corps loan repayment, as well as Nurse Corps. We cannot forget about all the spectrums of who provide care across our state. So in the interest of time, those are my welcoming remarks. I really hope that we have a robust agenda for you today. Appreciate everyone being here, and enjoy your day. Thanks so much.
And I will say that the crack in the stage is real. Anyone who's up here with high heels, beware. So, next co-chair is Julia O'Hanlon. She leads a wide range of public policy-related projects and provides salient research, support, and technical assistance to the University of Delaware Biden School of Public Policy and Administration's IPA staff, state and local government officials, and nonprofit associations. Julia's primary expertise involves state and local management, aging-related policy issues, big topic, intergovernmental relations, and public personnel management. Her recent public policy research activities have focused on program evaluation and funding of senior centers, researching healthy and walkable communities, and researching issues related to youth aging out of foster care in Delaware. She also serves as IPA staff liaison to the Delaware League of Local Governments, aiding in ongoing communication among staff, local officials, their staff, and IPA project leaders. She holds a master's in public administration from the University of Delaware's Biden School. Julia?
Good morning. I'll just echo what's already been said. It's a pleasure to see so many amazing people in the room today. And I've already seen a number of people who I recognize, but there's a number of folks who I hope to either get introduced to or connected with at some point. So thank you for being here. As Tim said, I'm with the Biden School of Public Policy and Administration's Institute for Public Administration. That's IPA for short. We've been around for over 50 years in the state of Delaware, working with a variety of state agencies and local governments. And our work really cuts across a lot of different areas. So today's work, as the staff liaison and with the League of Local Governments, and I also run our health and aging services, policy services at IPA. So this really cuts across a lot of our work, whether it's education policy, obviously access to care, including social determinants of health, transportation, housing, et cetera. And then also with our aging population and the demographic trends that we're seeing in this state. So I'm very happy to be here. I look forward to these amazing conversations, and that's it. Thank you.
Now I see what's happening when you walk up the stairs, the whole stage shifts. We'll do something about that on a break. So I wanted to point out in the program, the Planning Committee members, and I wanted to do a special thank you to Dr. Nancy Phan, Secretary of Finance for the state, Rick Geisenberger, and Painter, our own board liaison for the Academy DPHA, and Dr. Kate Smith, our executive director. And we've actually had a third co-chair in this who's been a partner on the side, so to speak, and that's Kathy Matt. Kathy, you have been absolutely fantastic at supporting us, greatly appreciated. And everyone, Dr. Kathy Matt. And at this time, I'll ask Nichole Moxley to introduce our first speaker.
Well, good morning again. It is my privilege to introduce Michelle Washko. Michelle Washko, PhD, is a national expert on the healthcare and health support workforces in the United States. She is currently the director of the National Center for Health Workforce Analysis in the U.S. Department of Health and Human Services. In this role, Dr. Washko leads the federal government's effort to broaden the evidence base around our nation's healthcare providers. While her area of expertise is the entire health labor force, she specializes in occupations and the long-term services and support sector. Dr. Washko joined the National Center for Health Workforce Analysis in August of 2013 and served as its deputy director from 2014 to 2018. Dr. Washko previously worked at the Administration for Community Living in the U.S. Department of Labor, where she developed employment initiatives for older workers. Prior to serving in the federal government, she worked as a senior research associate at Leading Age. Dr. Washko holds a PhD and MS degrees in gerontology from the University of Massachusetts and a MS degree in individual and family studies from the University of Delaware. Please welcome Dr. Michelle Washko.
Good morning. An advantage of being tall is that I am in flats. Thank you very much for that lovely introduction. I am Dr. Washko, and I serve as the director of the National Center for Health Workforce Analysis. Today I'll be speaking to you, and I think I need to put my presentation on. I might need, oh, I'm good? Okay, thank you. I'm going to be speaking to you about health workforce challenges and successes, but from a national perspective. And I feel a little bit I can't decide if it's disingenuous or good, but I feel like I'll be repeating everything you just heard from our previous speakers. So just an overview, because I like to start out my remarks with the end result. That way everyone remembers and also knows what you're looking for. High-quality healthcare starts with a well-trained, adequately supplied, and well-distributed workforce. So with this, there's several challenges first that are facing the workforce in the healthcare sector, some of which you've already heard. And while they've existed and persisted for a very long time, as you heard from Rebecca, the pandemic certainly made them more acute. These primarily include issues with supply, workforce shortages, maldistribution across the country, unequal access to care, and employment quality in this sector. I'm going to go into each one of these a little bit in depth. On the upside, though, because there is an upside, people and organizations have been attempting to combat these issues, and many of you in this room have, for a very long time. And in some cases, it's very deliberate, such as pushing for team-based care, integrated care, and in others, it's more serendipitous and situational, some creative solutions we all came upon during the pandemic. Great. For the first half of my remarks, as you just saw, I'm going to delve a little deeper into the challenges we face across all parts of healthcare and in nearly every occupation. I like to end on a positive note, so we'll start with the negative. As I just mentioned, and as you know, we're facing shortages in many healthcare occupations in this country. My center releases workforce projections on an annual basis, and the trend over the past 10 years, and of course for decades prior, but the science has gotten better, the shortages are getting worse. I'm sure that comes as no surprise. So we need to be able to balance supply with demand for care and expand the number of healthcare professionals. Now, beyond shortages, what we may perceive as a shortage sometimes, especially in a smaller geographic area like a state, county, even rural versus urban areas, it's oftentimes a result of actual maldistribution, not necessarily an actual shortage in numbers. So we need to improve workforce distribution by encouraging training and work in underserved areas. And as you've heard, and I'm sure you know this quite acutely, but access to care is a huge problem in this country for many reasons. But in terms of workforce, we need to increase and improve access to providers, making it easier for people to get the type of health care they need from the type of provider who gives that care. And then finally, labor market factors and employment characteristics can drive people out of work, out of this particular workforce. We need to improve the quality of employment. We need to address undercompensation for some occupations, burnout, workplace violence, so that we make people want to stay in this sector and not leave. So it's one thing to identify the challenges, but to understand how to address them and how to identify when we see a success, we need to understand the underlying causes. Well, these three areas that you see on the slide in front of you aren't the only reasons for broad workforce challenges in the U.S. They're certainly some of the biggest, and unfortunately, they're not easily addressed. I'll go into each one a little bit more in a moment, but in a nutshell, they include, one, major population shifts that have been afoot in the U.S. for generations. Two, distribution, always coming back to that. It's a seminal issue which drives the shortages oftentimes. And finally, as I just mentioned, those labor market factors and employment characteristics. Some are shared across the entire U.S. labor force, but they play a role both as a problem and as a solution. So let's go in a little bit deeper on these drivers, the population shifts. Our aging society is still the primary driver for demand growth in healthcare. Right now, about 17% of the US population is over 65, and by 2050, so about 25-ish, a little bit more years, this will jump to around 23%. In addition to them being the driver behind healthcare demand, they're also leaving the workforce. At the same time, the US birth rate has fallen by 20% since 2007. And that's not just when it started to fall, it's been falling for quite some time. Couple that with net international migration into the US being at its lowest levels in years, and we have a massive imbalance when it comes to available supply and demand. So, these three factors are what is really driving US labor shortages overall, and an inability of the healthcare workforce in this country to be able to meet the growing healthcare demands that are being required by this aging population that we have. Another major driver, the second bullet point I mentioned, is distribution. Sometimes, as I mentioned, we may have an occupation which appears to be in equilibrium at the national level, and I see this a lot. But if we look at smaller geographies, states, counties, rural versus urban areas, et cetera, the maldistribution is actually a shortage. That shortage can be felt quite acutely depending on where someone lives. A good example of this is the outlook for registered nurses in this country. We're about to release new numbers. Just last year, we released the 2022 National Sample Survey of Registered Nurses, which is a gold standard survey we do at the Census Bureau every 4 years. And what you can see when you go down to the state level is that nursing distribution demonstrates how gaps widely differ on a state-by-state basis. And this map that is up on the screen, the darkest reds are the biggest shortages, and the darkest blues are the biggest oversupplies. Now, at the moment, we're projecting a nationwide shortage of 9% by 2036. That number's about to go down a little bit, but that does not tell us the whole story, because in some states, that shortage is in the high double digits. Redistribution of providers and using existing provider skills as expansively as possible, harnessing technology, these are things that are part of the solution. I love the program bulletin here, the program you have in front of you, because it actually called out some of the things that we as a nation are doing to address this. So HRSA programs like the National Service Corps, which you obviously heard mentioned before, and Nurse Corps, teaching health centers, they create opportunities and incentives for providers to choose to work and train where they are most needed. Is this the only solution? No, but it is a big one. And I'm going to pepper this because I am a researcher, I am a scientist with data insights in between. Another, perhaps I would say, more acute example of how workforce maldistributions negatively impact care can be seen in women's health. The US has a high maternal mortality rate compared to other high-income nations. As many as 60,000 women in the country experience severe maternal morbidity resulting in short and long-term health problems. There is an existing 13% shortage of OBGYNs by 2036, and in numbers that we're going to release very soon, that shortage is going up to 18%. You might go, 13%, 18%, that's one provider. We know that there's nurse midwives. We know there are other occupations who provide women's health care. But as of 2022, over 10 million women, so 16% of all women over age 18, that includes me, live in the US in counties with no OBGYN physician at all. Back to the drivers. There are large labor market factors and issues in employment that add to the challenges facing our healthcare workers. There's issues with our educational pipeline. For example, we're facing shortages of nursing faculty in this country. I'm sure that comes as no surprise. This means less people are able to be trained as nurses, resulting in a smaller addition of new workers into the supply on an annual basis. Undercompensation is a major issue, especially for occupations facing critical shortages like primary care physicians, and for many easy entry occupations, as we call them, such as direct care workers. In that latter case, they can get siphoned off into other industries. I'm sure you've well heard the comments about why should I work in a nursing home or home health care if I could go work at Walmart for the same amount of money. Poor working environments that produce high stress and burnout have long been issues. The COVID-19 pandemic, as we all know, exacerbated them, when workers experience long hours, exhaustion, exposure to death and suffering, and a fear for their own health and safety. So again, these are not factors that are easily tackled. They actually impact various other sectors, so we're not alone in struggling with these challenges and these drivers. Again, peppering with a little bit of data insight, and I love that video at the beginning about the importance of primary care. So as we know, primary care physicians have much lower wages when compared to other specialties, and they also, as you know, receive less reimbursement for treating patients who receive Medicaid and Medicare. This leads to many medical school graduates choosing other specialties, which then contributes to these persistent shortages in primary care physicians like family medicine, like geriatrics. And as you can see on this map, the majority of the US states are experiencing shortages for these providers. Same thing, the dark red are the worst and most persistent shortages, and then into blue. We have no dark blue. So in this case, even if we attempted to redistribute primary care physicians, it does not fully solve the problem. Rather, if we can improve labor market and employment conditions, that's going to be a better solution. Now, gone through the negative. Like I said, I like to head into the positive. So let's talk a little bit about successes. Despite all of these challenges, despite these underlying issues that I've brought up, there actually are solutions that are within our reach and that many of us have been engaging in for some time. While we can't really change population drivers like aging or fewer births, we can increase supply and produce more providers if we can grow the number of students entering into healthcare and graduating. And when it comes to distribution, we can encourage providers to work in rural and underserved areas with incentives like loan repayment programs, but we can also encourage team-based care, integrated care, to kind of mitigate some of that maldistribution. When it comes to access, can't solve all access problems with health workforce solutions, but we can continue to diversify our workforce, which will help us reach underserved communities. And further, we can continue to harness technology, such as telehealth and now AI, to improve access. And last, we can promote provider resilience and healthy labor force conditions when employers invest in living wages and nurture the mental health and wellness of their staff. We have ultimately seen this reduce employer costs and actually improve workforce retention. Another data insight. I do love my data. The growth varies, I'm going to address the first thing I mentioned, which is the supply pipeline. As you can see on this slide, medical school enrollment has actually increased by 6% over the past 5 years. That's through the pandemic. And similarly, the number of newly licensed RNs each year increased by 36% during the same time frame. And if you dig a little bit deeper, it's actually an even more interesting story. The growth for medical school and medical students varies by gender. While the number of female medical students has grown by 14% in the same time period, those 5 years, the number of male medical school students has decreased by over 3%. So now female students are 55% of medical school enrollment, especially in the past year. When it comes to the nursing number, there's over 4 million registered nurses, including APRNs and LPNs as of last year. That number increased by 5% between 2019 and 2023, and during that period, the number of NPs grew by 35%. But again, don't be fooled by those numbers, there is maldistribution. In some occupations, increasing foreign educated workers is actually alleviating supply issues. And we've seen that with registered nurses. In fact, the NCLEX pass rates for foreign trained nurses doubled every year since 2022. And I've actually spoken extensively with people around the country, and no one really has an exact reason why, except that we think that potential changes in the test and an emphasis on actual care and practice are helping more people end up in our pipeline. So statistics like these, despite everything, show that there is a continued interest in healthcare careers and continued growth in the workforce. And though I've focused on these two professions, they are not the only ones. So that's a little bit of a light in the darkness. Another data insight that helps with distribution, team-based care and integrated care. as you hopefully know, we need to rely on all professions in a sector, not just individual occupations. Right now, my center, we are projecting shortages in all 4 primary care physician specialties. This is not new, but those shortages are getting worse. But we have surpluses in primary care nurse practitioners and physician assistants. Following the trends of the past several decades, with these worsening physician shortages, and the fact that NPs and PAs are not experiencing the same situation, they can't supplant primary care doctors. Or in the case of behavioral health, where we also see primary care providers offering up behavioral health services, the surpluses in the advanced practitioners can alleviate the physician shortages, to an extent by making up for some of the distributional imbalances. This is huge because primary care physicians and their shortage has a profound effect on those seeking primary care and women's care and behavioral health care. And the other primary care providers, nurse practitioners, PAs, they are important providers of these services as well. So we can treat some of the distributional issues by tapping into providers who are perhaps located where there is a supposed shortage / maldistribution. And my last data insight, actually not my last data insight, but another data insight in terms of technology. I know you've heard this before. Technology has improved access. And I'm going to give you an example again from behavioral health, another part of the health sector which is experiencing severe shortages. There are shortages projected for 10 of 12 major behavioral health professions. And in a study released by my colleagues at SAMHSA, the Substance Abuse Mental Health Administration, their 2022 National Survey on Drug Use and Health found that over 6 million, I think it was close to 7 million adults in the US have a perceived unmet need for mental health services. But, remember I mentioned serendipitous and situational solutions? The pandemic did offer a solution in the form of telehealth. And I think you probably know this. Telehealth services can help overcome access barriers for individuals in underserved areas, and they can provide benefits for urban dwellers as well. Less than 1% of behavioral health outpatient visits were conducted via telehealth before the pandemic. And then in 2020, that usage jumped to 40%. And there have been studies since. While some waivers and things like that have expired, the use of telehealth has remained pretty high. It has not dropped back down to that 1%. It also mentioned the primary care physicians used telehealth more during the COVID-19 pandemic than prior to 2020. So it wasn't just in one particular part of healthcare. Everybody who could was tapping into it, and is. And the last data insight that I'll give you when it comes to successes is around provider resiliency. And this one's a tough one, right? Because we know it was a problem before the pandemic, and we know it's still a problem. It's persistent, and we really have, as a nation, not come up with any perfect way to solve it. But what we are seeing are some slight shifts. The American Medical Association releases numbers on resiliency and burnout every year. And what they're seeing, or what they've seen, the trend over the past couple of years, has been that, well, at the height of the pandemic, physicians were reporting experiencing at least one symptom of burnout, and it hit a high of almost 63% in 2021. For the first time, physician burnout has fallen below 50% since the pandemic. So you can see that demonstrates that the issue is persistent and the pandemic brought attention to it, but we have to remain committed to improving the well-being of all healthcare workers. And RAND actually released a study showing that when employers treat and nurture that mental health and well-being of their workforce, they reduced their costs for their employees by about $360 a person. That's significant when you talk large health systems. So I will end again with my first slide, but reinterpret it slightly. Some takeaways. If you take away anything from my remarks this morning, note that while the challenges that we're facing the healthcare workforce are persistent, and the underlying factors that drive them are large, and we're not going to solve them all today, they are not completely insurmountable. There actually are ways we can address them. I've given you some examples. I know that there are more. And if we continue to be creative, opportunistic and try new strategies, work together, we will be able to mitigate some of them. Thank you.